Hello, welcome back to my IVF Answers. I'm glad to be here back with Dr. Vladimiro Silva. You can see him right here. Apologies for being a little bit late, but we are here and we are ready to answer all of your questions. Well, definitely Vladimiro Silva is ready to answer your questions. I'm glad to be back here and we are going to discuss an important topic. What is the role of endometrium in repeated implantation failure? And of course, we will start with the presentation, but after that, there will be time for your questions. And Vladimiro is here to help you with that. Hello, hi, Vladimiro. Glad to see you here. Welcome
Hi,
back.
hi,
Last
Carol.
time you've been here, it was still a year, I mean, not a year ago, but of course, last year.
Last year.
So we are starting again, and I'm glad to have you back. How are you? Hope you are ready to educate us a bit.
Well, hi, Carolina. Thank you for having me here. I'm sorry, everyone, for being late. I was really stuck in traffic. I know that it seems like the oldest excuse in the world, but that's exactly what happened with me. But now I'm here. I'm very happy to talk about this topic. Actually, in the past, we've addressed this topic in other webinars, maybe not in a dedicated way. But so let's go over everything we have here, and then we can have a little conversation at the end. You can ask your questions. I'll be very happy to answer everyone. I don't know
Sure.
if you can see my screen.
Not yet. Let's try
Okay,
again.
there okay. No, apparently you should be seeing my screen, right?
Right now we can see your screen, not your presentation yet.
Okay. So here's the presentation. You can see it, right?
Yes.
Okay, perfect. So
It's
let's start.
working perfectly now. Let's go ahead.
Okay, so once again, thanks for being here, listening to us. Today we're going to talk about the role of the endometrium in repeated implantation failure cases. My name is Vladimiro Silva. I come from Ferticentro. Ferticentro is a clinic in Portugal, in a town called Coimbra, in the center of Portugal. It's always a pleasure to be here. I have to thank the European Fertility Society for the invitation. We've done quite a few webinars on this and other topics. So let's start. The first thing that, while looking at this title, the first thing that comes to mind is obviously, what is this? Okay, what's a recurrent implantation failure? What's the definition of it? Well, actually, there's not much consensus on the scientific community of what should be considered as a recurrent implantation failure, but normally we refer to it as the failure to achieve a pregnancy after at least 3 embryo transfers with good quality embryos, or maybe after the transfer are 3 or 4 nice blastocysts. What does this mean? It means that first, we talk about this when we are always talking about the same strategy. For example, if you are trying with your own eggs and you're getting great blastocysts, you transfer 3 or 4 of them and you're still not getting a pregnancy. So you can talk about recurrent implantation failure, but obviously if you are, say, 43, 44 years old and your embryos are not that good, then not having a pregnancy after 3 or 4 blastocysts, it's unfortunately more likely to happen than the opposite, and so we cannot talk about recurring implantation failure. The same with egg donation. You can even be 48 or 49, and you're trying with egg donation with 3 brilliant embryos, and you don't get a pregnancy, then you can talk about recurring implantation failure. So it's a little bit, we need to go case by case, but essentially is this: following the same strategy, 3 attempts, or at least a sensible number of nice blastocysts, which means very good looking embryos. Okay. Sometimes some people argue that this is really just bad luck, because obviously when we are doing these treatments, we know that 2 persons age 25, if they try naturally, we as humans are not a very fertile species. So a man and a woman at the age of 25, if they try to get pregnant naturally, if they are in perfect health without any reproductive issues or any other concerns, they just have a 25 to 30% pregnancy rate in the natural way every month. And obviously in IVF, for example, when we are doing egg donation, we are just very above that. For example, we can easily get to a 60% pregnancy rate or a 70% pregnancy rate with egg donation. But obviously, statistics are what they are, and they can deceive us. For example, if we have 60, this is to show you how numbers can be played. For example, if we have 60% pregnancy rate, which is kind of the standard for egg donation, and this means that if we transfer an embryo to 100 patients, 60 of them will become pregnant, obviously. 40 will not become pregnant. We go to the remaining 40 and transfer another embryo, and so 24 will get pregnant, 16 will not be pregnant. And if we go to the 16 and transfer a third embryo, 9 will be pregnant, 7 will not be pregnant. So after these 3 embryos, we can say that we had a 93% accumulated pregnancy rate, but in reality, it was always 60%. So statistics depend a lot on the way that we look at them, okay? And it's not, so we should be careful. We can't make overall assumptions. It's really important when we talk about repeated implantation failure to know what we're talking about. Very important. We need to make sure that there are no confounding factors, meaning if the embryos are really good, if the endometrium, which is the tissue inside the uterus, is also good, then we might need to take a deeper look into it. If those conditions are not assured, maybe we're just on the wrong side of statistics, but we need to be careful not to believe in the 93 or not, but always have in mind that it's always 60. Okay, so 60, it's every 10, 4 don't work, 6 work, so it's relatively low odds. And but because the reality is that IVF treatments fail, and many times we don't know why. For example, there was this study published a few years ago in Human Reproduction Update, which is one of the main scientific journals in the IVF world. This is the official journal of the European Society for Human Reproduction and Embryology, the ESHRE, where these researchers have concluded that normally when patients are not getting pregnant, they often come to the clinic and say, why did it happen? Why is not working for me? And so was it the egg, the sperm? Well, according to this study, in 70 to 80% of the cases, it was the egg. In 10 to 15% of the cases, it is the sperm. And in 10 to 15%, the causes rely on the endometrium. And today we are talking about this 10 to 50%, which are the endometrial causes for implantation failure, knowing that in 85 to 90%, the problem is not the endometrium, is the embryo, okay? Obviously, for example, the sperm can play a role even before the formation of the embryo, but also afterwards, because in some situations of sperm problems, the risk of miscarriage is increased. Okay, so it's a little bit like this. So just going back to what I was saying, we're talking about the endometrium today. The endometrium is this tissue that coats the inside of the uterus, but this is only responsible for 10 to 15% of the implantation failure situations. According to these statistics, obviously, we don't know. There's no consensus also about this. Just to go a little bit on what I was saying, obviously, when the problem is with the embryos, we're talking essentially about chromosomal abnormalities. And when the problem relies on the uterus, we can have a problem in the endometrium, which is the topic for tonight. and then we have the window of implantation, the endometrial receptivity issues, but we also have anatomical abnormalities, immune factors, things that are not directly related with the endometrium, but rather with the uterus and some malformations and so on. So a little bit just to explain on the embryo side, because it's also important to have in mind that when we are addressing a topic that concerns 10 to 15% of the cases, it's important to say that we're typically only concentrating on the endometrium after we exclude the problems with the embryos, because 85% of the time, 85 to 90% of the times, this is where the problems are. And so the main way for us to exclude problems with the embryos is by analyzing genetically the embryos with the pre-implantation genetic testing for aneuploidies, the PGTA. What are aneuploidies? These are numerical chromosomal abnormalities. This means that your endometrium has your embryo, has the wrong number of chromosomes. Either it has one extra chromosome. The most well-known case is trisomy 21, Down syndrome, where we have 3 chromosome 21s. We all know cases like that. And obviously there could be missing a chromosome or among other factors. And the problem is that these situations are typically age-related. What does it mean? It means that with the progression of female age, so this is connected with the female age, on a significant minor degree with male age, but essentially with female age. We know that with the progression of female age, this type of chromosomal abnormalities increases, and obviously that causes the embryos to be to carry anomalies, and so that are not compatible either with implantation or either with having a healthy baby. For example, these are some statistics that these were taken from the iGenomics website. iGenomics is one of the main labs in these fields of reproductive genetics, and we can see here on the gray bars, it's kind of gray bluish bars, that for example, for all ranges, for all age classes, the probability of pregnancy with PGTA, meaning screening the embryos for chromosomal abnormalities, are pretty much the same. There is a slightly difference. However, if we look at the orange bars, in a non-selected population, pregnancy rates go down with the progression of age. Why does this happen? Because obviously in the gray bars, we're just considering the transfer of embryos that have a normal number of chromosomes. But so PGTA doesn't improve the quality of the embryos. Okay, if an embryo is not good, this is not what changes the embryo. It just helps us to understand what's happening, and it tells us whether the embryo is viable or not, and that helps us to make decisions, to focus our clinical investigations, to try to understand why treatments are not working in the endometrium and in other factors. So this is kind of the first step to study the endometrium, is to understand whether the embryo is viable, because you can see here that even for the best possible cases where the patient is below 35 years of age, where we are transferring an embryo with the correct number of chromosomes, pregnancy rates are never above 60%. Okay, this means that in the remaining 40%, we have the other causes of implantation failure. Okay, and this is where the endometrium lies, and obviously there could be other factors, but this is probably the uterus is on the missing part of this graphic, the pregnancy rate that goes from 60 to 100. So nature brings us until here, but the endometrium is kind of preventing us to reach here because the embryo is supposedly normal in this part. Okay, and then we can see the same situation in terms of miscarriage rates. On the right-hand side, this is sort of the explanation for the left-hand graphic. You can see here that in the orange bars that the probability of miscarriage increases a lot when we are transferring in an unselected population, while in a selected population where we're just transferring normal embryos, pregnancy rates are, miscarriage rates are pretty much the same. There's a slight increase associated with age, and those are, again, probably endometrial factors, but it's relatively steady on the gray bars with age when we transfer good-looking embryos. So going back and just to say it one more time, when we are addressing the quality of the endometrium and talking about the relationship between repeated implantation failure and the quality of the endometrium, the first thing that we need to exclude is whether the problem wasn't in the embryo, because we know that the probability of the problem being in the endometrium is relatively low. It's like 10 to 15%, as shown in the previous slide. So let's say we are transferring good quality embryos, nice blastocysts, or maybe PGTA tested embryos, and we're still not getting a pregnancy after those 3 attempts, or after the transfer of 4 embryos for nice blastocysts. So what can we do about it? So let's try to exclude the problems with uterus. One of the first, well, in recent years, this was kind of launched 10 years ago. One of the tests that was most used around the world was the endometrial receptivity test that is called the ERA test. I'm sorry, I was moving a little too fast. So we need to address endometrial receptivity, and that has 3 parts. One of them is the window of implantation, another one is the microbiome, and the third is the assessing whether there are any signs of chronic infections in the uterus, what we call chronic endometritis. So, talking about the window implantation, the endometrial receptivity array, the ERA test, there are other brands doing the same. What is this? This is about the window of implantation. This is also another graphic from iGenomics. Just for you to understand the principle, in a normal cycle, in a physiological cycle, we know that the cycle starts on day 1. We have the ovulation around day 14, and then between day 19 and day 21 is when the endometrium is ready to receive and implant an embryo. Okay, so this is what we call the window of implantation, where the endometrium is ready to receive a blastocyst, which is a day 5 embryo, and we know that before this the endometrium is pre-receptive, and after this the endometrium is post-receptive. Why is that the endometrium being receptive? It means that the endometrium starts to be under the action of an hormone called progesterone. It starts to be more vascularized and ready to receive, implant, and nourish an embryo. So obviously the window of implantation sometimes is not the same for all women, and 30% of the patients have a displaced window of implantation, according to studies that have been made. And so what happens, this is also a graphic from iGenomics, is that when you transfer an embryo, a day 5 blastocyst, it needs to be within the window of implantation, and this window of implantation can be corrected if, for example, the endometrium is only receptive later or earlier, and so we need to adapt the moment where we will transfer the embryo. Why? Because we know that the endometrium needs to be ready to receive the embryo. So if it is a blastocyst, it should be at 5 days of progesterone, because that's when the endometrium is ready to receive a day 5 blastocyst. However, we know that in some cases the endometrium after 7 is only ready to receive an implant, an embryo after, for example, 6 or 7 or 8 days of progesterone, or the opposite, after 3 or 4 days it is already ready. With day 3 embryos, nowadays almost no one is using this, but back in like 10 years ago or whatever, 7-8 years ago, we were still doing some cases of day 3 embryos. It's the same logic, it just happens 2 days before. Okay, so and obviously when we are outside the window of implantation, the chances of having a pregnancy are lower, the risks of miscarriage are higher, and there is a risk of us wasting precious viable embryos for transferring them in the bad moment. How can we correct this? It's actually relatively easy. We prepare the First of all, we do cycle preparation like if we were doing a frozen embryo transfer, exactly the same way, except that on the day of the embryo transfer, we will do on the day of the embryo transfer, instead of doing the embryo transfer, we take a little piece of the endometrium and that goes to be analyzed on a genetics lab. They ran a panel for 248 genes, and the result will be one of these. And the endometrium is receptive, and we know that. So since we did the biopsy at 120 hours of progesterone, we know that at that very moment the endometrium is ready to receive an embryo, or for example, the endometrium is still pre-receptive. This means that, for example, this is an example of a real case where they recommend that the embryo transfer should be done a day later than the moment where the biopsy was taken. What does it mean? It means that we should transfer a day 5 embryo to a day 6 endometrium, okay? Because this particular patient needed an extra days to have her endometrium ready to receive and implant an embryo. Okay, sometimes when the results are not conclusive, we need to take another biopsy, but the most important thing here is that we need to find what is the best moment to do the embryo transfer, and it doesn't require special medication or nothing special. It's really just having an embryo transferred in the right moment to optimize the uterine conditions. According to iGenomics, this is obviously a study made by one of the main labs producing these tests. So like I was saying, 30% of the patients have problems in the window of implantation. So patients with repeated implantation failure, so patients within the conditions that we've established in the beginning after at least 3 failed attempts. And so doing this particular test on those patients produced better results. Transferring on the day that is supposed to be done 54% of pregnancy. Using this information, they moved to 70, they gained 18% of pregnancy, and the cumulative rate went from 70 to 95%. And obviously, the time for a pregnancy was also reduced because 71% of the women, of all women, gave birth within 1 year. This is obviously these are the results of a study made in certain very specific conditions. Okay, then there were studies done in a larger scale where they were doing this test to all patients regardless of their conditions, and that the test proved to be useless. Okay, so these results were actually challenged. This means that this is now my opinion, and obviously not just mine. A lot of people share this view. So we can't do the ERA test to everybody because it makes no sense. We would be doing biopsies that are useless, and for some patients, this is not a factor. However, for patients that have a documented repeated implantation failure case, there is some beneficial in doing these tests. This needs to be looked at with caution. It's up to the IVF specialist to take a look at it and decide whether it makes sense for the patients to do this test or not. This is not a magical bullet that will solve the problem. Okay, it's just another tool for us to have a better understanding on how we can optimize the results, and it will only work on a restricted number of patients. Obviously, patients that have been subject to a series of repeated implantation failure events in the past. Another thing that we look at, and this is something that is a lot more consensual than the ERA test and the window of implantation test, is the microbiome and chronic endometritis. What is this all about? So even though in the past, until a few years ago, medicine, doctors believed that the uterus was sterile, it was proved that in fact there are bacteria inside the womb. Obviously, these need to be the right bacteria. Okay, so we call the microbiome then to the kind of the environment of bacteria that exist inside the womb. And we know that these need to be at least 80% lactobacillus. Okay, what does it mean? It means that we need to have the right bacteria inside the uterus to prevent the wrong bacteria, the pathogenic bacteria, to implant and create an infection, a local reaction, and so on. Because we know that the balanced microbiome with at least 80% lactobacillus will improve your reproductive prognosis, obviously resulting in an increased chance of pregnancy and live births. We've seen in many studies that have been done in recent years that 30% of all infertile women have pathogenic bacteria in their uterus. And there are numerous studies that show that having pathogenic bacteria and other, and so not the right bacteria, let's put it this way, is very linked to embryo implantation failure. So what we do is this: when we do exactly the same as before. So we do as an artificial cycle. It can also be done on a natural cycle, but so we do an endometrium preparation cycle. But on the day where we should be doing the embryo transfer, instead of doing the embryo transfer, we will just do an endometrium biopsy. So we take a little piece of the endometrium and we send it to be analyzed on a genetics lab. We can use that piece to check for the 248 genes related with the window of implantation that we've just discussed, but we can also check to see what bacteria are in there. And so, for example, we work with iGenomics in these two cases, but again, there are other labs doing pretty much the same. And so we use a test to see to have a view of the endometrial microbiome composition, okay, and see if we have the right percentage of lactobacilli, and then we can see. We also use another test that is called, in this case, ELISE, but there are others, to see if there are bacteria associated with a chronic endometritis, and obviously from those results, we get a recommendation on what is the antibiotic that we should be using. For example, this is also a real case from a real patient where we had the result was a mild dysbiosis profile. And so there was a problem here because we can see that lactobacilli were just 59 instead of 80%, but there were no pathogenic bacteria involved, so they didn't find out any of this. So what we have done here was just to give probiotics to the patient. Sometimes we give the probiotics and we do another biopsy to confirm it, sometimes not. For example, in this case, we did not do that because it was a mild change, so it was not a very significant case, but we've had cases where the percentage of lactobacillus was 0%. Okay, that happened. And in those cases, we give the antibiotic just to kill potentially harmful bacteria, and then we give the probiotic to populate the uterus with the right bacteria, and then we check again to make sure that everything is fine, and then we move on with the embryo transfer. So sometimes we do it in one way, sometimes we do it in another way. It has to do with the specific case of each patient. There is not a universal solution for every patient that we can say we always need to do it like that. Another thing that we should that we should check while evaluating the uterus. Not in this case, this is not specific for the endometrium, but we're talking about anatomical abnormalities. So what is that? Well, there is a test, an exam called hysteroscopy, where we go with a video camera to see the inside of the womb, and this is used to check for polyps, to check for endometritis, because we can also do a biopsy along, check for myomas, also known as fibroids, adhesions, adenomyosis, malformations, etc. Obviously, some of these can be surgically corrected, some don't. Endometritis is treated with antibiotics, as I've explained. So we need to take a look. Obviously, for example, we know that, for example, this is a study that showed that congenital uterine abnormalities can lower the reproductive outcome. So there's no discussion around it. There is consensus about it. However, for example, there are surgeries that make sense and some others don't make sense. For example, in this review from the Cochrane Library, this is kind of a specialist committee sponsored by the World Health Organization. For example, they say that, for example, in women that have septum, there is no evidence to support a surgical procedure in these women. So they say that it's preferable not to remove the septum because it's a surgery, it's aggressive, it can actually do worse than not to remove it. Obviously, if a patient has repeated miscarriage or repeated implantation failure, we can look at it in another way. But as a first approach, for example, so surgeries are not always recommended. That's the take-home message here. There is also something that is always very discussed, and now we are talking. So remember, when I started this, I showed you a slide saying that the problems with the uterus represent 10 to 15% of all cases, and now we are on those 10 to 15% percentage. We are talking about small pieces of those 10 to 15%, and this is probably the smallest of all of these pieces, the immune and dermatological tests. There are a lot of tests in the market. There are people, tests for NK cells. In France, for example, there's a test called Matrice Lab, where they test for the immune environment at the uterine level. There are a lot of people testing for KIR, HLA-C. There are panels that screen for autoimmune diseases, screening panels for thrombophilia. There is a lot of stuff. not all of this is proven. Actually, most of this is not proven, because in order to prove the effect of these benefit of doing these tests and correcting for these factors, you will need to do large-scale studies, which are extremely difficult to do, not only for financial reasons, but also because you would need to find a large number of patients exactly with the same problems. And it's very difficult to find a sample, because in IVF, there is always a lot of factors. It's the egg, it's the sperm, it's it's every patient is a single case, and so it is very, very difficult to gather a number of patients where they are all alike, except for the fact that they might or not might not have a problem with an autoimmune disease, or because they are KIR A or HLA. C1, etc. So this is something, none of this is completely proven. We also do this, okay? No question about it. From this, the one that we rely more is the KIR HLA. We're doing that a lot, and we've seen a lot of cases where, after correcting for these factors, it was possible to have the birth of healthy children and people having healthy pregnancies. This is sometimes a little painful, because it takes a while for patients to get, especially when working with donors. When there are no donors involved, we need to give to the patient special protocols to the patients. So there is a lot to be done, but obviously it's part of our reality. I was hesitating before talking about protocols here, but I preferred not to do it, because again, patients are all different, and these protocols need to be personalized. This is not something, it's not a one-size-fits-all kind of case. It's something that we really need to assess on a patient basis, okay? Because obviously, at the end of the day, what we want is this to happen. This is a blastocyst implanting in the uterus, and so that's it. I'm also, because in a previous presentation on this topic, I was asked to show some examples of real life cases, and I decided to bring them back, because these are obviously all fake names, but these are real cases that we had at Ferticentro. For example, in the case of Jenna, this is a 42-year-old lady with 5 years of infertility, 2 previous miscarriages. She had multiple fibroids that were surgically removed by laparoscopy. She had them removed before coming to our clinic. She presented with a low ovarian reserve, so we did her an egg accumulation. So we did her 2 stimulations. The first one just to freeze her eggs, the second one to get more eggs, and then we did the IVF with the previous frozen eggs plus the fresh ones. We ended up having 1 blastocyst. We did PGTA, pre-implantation genetic testing, and the embryo turned out to be aneuploid, meaning it was not viable. So we had to discard that embryo, and then we did an egg donation treatment. We had 3 blastocysts. All of them turned out to be aneuploid again, which was kind of strange. We were not sure whether this could come from her or the husband. So we tried again, and without any plausible or evident explanation, anything but luck. So we ended up with 6 blastocysts. 5 of them were euploid. So problem solved. We transferred the first embryo. Well, actually, not right away. So we transferred the first embryo, and the result was negative. And then we did the ERA test, and we we verified that the endometrium was only receptive at 144 hours, so there was a 24 hours delay. We also did a thrombophilia panel. There were multiple positive results, so this patient had a lot of issues. We referred her to an hematologist. The hematologist put her on an individualized prophylactic protocol for these thrombophilia factors. And then finally, she had a pregnancy with the birth of a baby boy. So this was the end of this case. We also have another case, Pauline, 30 years old, 2 miscarriages already, polycystic ovarian syndrome, also a male factor. This patient didn't want PGTA, okay, because when we have 2 previous miscarriages, there is a clear indication for PGTA. It's also one of the situations where we don't need approval for that because the indication is very clear. So we did an ovarian stimulation that went really well. Despite the male factor, we ended up with 6 nice blastocysts. We froze them all. Until we transferred the first one, and we had another miscarriage, which was the patient's 3rd miscarriage. And then we transferred the second embryo, another nice blastocyst, and the result was negative. So what we did was we asked her to do lifestyle corrections because this patient was a little bit in overweight. This was back in the days before we were doing these Emma and Alice tests. So we did probiotics and antibiotics prophylaxis. We gave her a high dosage progesterone protocol because we ended up checking for her progesterone and the levels were not very stable. And then it was another healthy boy that was born after all of this. Again, this is something that shows up that we really need to take a look at what's happening with the patient. This is another case, Nathalie. She was 44 years old, low ovarian reserve, egg donation cycle. We ended up with 4 blastocysts, which is normal for an egg donation case. We did an elective single embryo transfer cycle, and the result was negative. We did a second cycle. The result was negative again, and then we tested her for the window of implantation and also for the microbiome and the chronic endometritis. So first of all, receptiveness only at 146 hours, and only 26% of lactobacilli. Okay, so this means that there was a dysbiosis. We screened her for immune factors, and we accidentally found out that she was a carrier of an autoimmune disease. The patient was not aware of that. She was also a carrier of a factor V mutation on the thrombophilia screening. So what we did then, obviously, we were working with the doctors from endocrinology for the other diseases, and then we did a 3rd protocol following the same protocol that was done with the IRA test, with probiotics, with the antibiotics, according to the recommendations that we got from iGenomics. We worked with the endocrinologist and the hematologist for the thrombophilia and autoimmune diseases. We've adjusted the protocol according to their recommendation as well, and the treatment finally worked at embryo transfer number 3. So this is the 3rd best embryo, okay, because we always started with the one that looked better and then the second one, and it was only on the 3rd that we got success. Also, after correcting all of this, was this really the endometrium, or were we just lucky because we've maybe only transferred the best embryo on the 3rd embryo transfer? We will never know. Okay, in principle, there are objective reasons for us to believe that it made sense, all of these corrections. So we don't think this was a coincidence, but obviously we don't have any proof of that. And this is kind of a testament of how it works. So we need to check, we need to evaluate, we need to make decisions on what we've seen. Again, it's not a one case fits all situation. We have multiple situations that can happen, but we are here, and this is why we go to work every day. If you need more information, you can find us online. I'm very happy to answer questions, and so I'm passing the words back to you, Caroline, and I'm available to answer all of your questions.
Thank you so much indeed. As always, an interesting presentation with lots of details, but we are ready for your questions. So remember to type those in the chat. All is anonymous, so don't hesitate. Vladimiro is right here for you to answer them. And let's go. We have some questions ready actually. So let me go to the first question. So I have endometriosis, but my uterus and endometrium is okay. How thick must the endometrium be before IVF? Thank you for your first question.
Okay, actually, I should have mentioned this. It was because I was focusing a lot more on the tests. But first thing, endometriosis is when you have endometrium growing outside the uterus. Okay, the endometrium is the tissue that coats the inside of the uterus, so it should be inside the uterus, not outside the uterus. And when it grows outside the uterus. I'm sorry, are you, because I'm having some warnings that my internet connection is not okay, but it's fine.
We can hear you fine, so it's all
okay. Okay, good. So endometriosis has nothing to do with the quality of the endometrium here, so you don't need to worry about that if that's the case. So regarding the thickness of the endometrium, the ideal is that the endometrium is above 8 millimeters of thickness. Above 7 is already okay. Above 6, it's we have pregnancies. Below 6, we also have pregnancies, but these are more difficult. Okay, so normally what we say, we always try to get 8. Okay, and if we don't get 8, we prefer to start over and try a different protocol, a different approach. If after some attempts we don't get to at least 8 millimeters, we will see, and we will work with what we have. Obviously, sometimes we use PRP, growth factors, etc. These are also strategies that are not completely proven, but we actually have some good results with them. But this is normally what we say is that those are for sort of more desperate cases. When the traditional proven therapies are not working, then we can start trying things that are still more experimental to see if we can get results. But obviously, we had children born from 5.8, 5.6 endometrium. Obviously, that doesn't happen every day, but so we always aimed for 8 millimeters.
Okay, thank you for your first explanation and your question, indeed. And let's have a look. Next question. Endotrio test came back normal. Endometrium always looks perfect. 3 failures with PGT tested. 5 failures altogether. I tried immunology treatments too with no success. Previously naturally conceived the pregnancy. What are my options?
Well, this is a difficult case. Okay, so the problem with this case from this patient is that she did endometrial test. What does it mean? So those are the tests that I was talking about, where they test for the window of implantation, the microbiome, and the chronic endometritis. And the endometrium apparently was okay. She says also that the endometrium also looks perfect, always looked perfect. So probably she's talking about the thickness of the endometrium. Then 3 failures with PGT tested embryos. I would go for those very rare cases of for example, one of the things that we would definitely try in this case was the test for the KIR compatibility. Normally, for example, this is kind of complex, but in the uterus, there are some genes called the KIR genes, and in the embryo, there are other genes that are called the HLA-C genes. And so we need, when the genetic profile of the uterus is KIR-A, there could be a problem of compatibility if the embryo is HLA-C2, okay? And obviously we receive an HLA-C from our father and an HLA-C from our mother. And so while forming the embryo can be C1C1, C1C2, and C2C2. If the embryo is C2C2 and the uterus is KIR-A, there is a risk of implantation failure, miscarriage, preeclampsia, lots of problems during the pregnancy. So it's a complicated situation. There are protocols that we can use with steroids, with growth factors, and so on, that can help us with aspirin, that can help us to control for that risk, but it's not the ideal. In some situations, we need to involve donors in order to solve the problem. We had at Ferticentro a case very similar to this one. This patient she had, on top of all of this, 6 miscarriages, and we've tried everything with her. And actually, it only worked when we did double donation. We transferred her PGT tested embryos. We did her the KIRS. We did her everything you can imagine and something else. Okay, because not just us, because she was already being moving from clinic to clinic. She had maybe 10 years or so, and so we ended up doing double donation, and that's when it worked. Actually, the child was recently born, and the only explanation that we can think of is probably some immune factor that was never found, that was solved by replacing one of the gametes involved, meaning the egg and the sperm. And we worked with 2 donors that had a good pregnancy record in the past, so that's when we did it. So the good message from this case is that even for the apparently worse prognosis cases, there could be hope. In this situation, we would need to take a look, because this patient also had a natural pregnancy, which is kind of even more strange. Sometimes these immune problems are triggered by a first pregnancy, and they develop immune rejection for a second pregnancy. That can happen, obviously, but I really don't know what. We would need to take a look and study it.
That makes perfect sense, obviously. So thank you so much, and I believe that helped you. And Emily has a question regarding NK cells. So are NK cell tests for blood better than uterine NK cells cell biopsy?
I'm sorry, let me see. Are NK cells for blood better than uterine? It's very difficult to answer this question. So first answer, we don't know. Okay. If I had to choose, I would prefer to rely on the results from uterine NK cells. Apparently, those are more related with the cases of immune rejection at the uterine level, but the reality is that, for example, this is not proven. Okay, this is one of those tests that still needs to have large-scale studies to prove. A lot of doctors and clinics are working and making decisions based on that, but it's what I was telling during my presentation. It's like the desperation stage, when everything is apparently okay, we don't know where else to look, and so we try to solve these, to work with these things that are not completely proven. So none of them is proven. If I had to choose, I would go with the ones inside the uterus. Those seem more important, but the reality is that there is no consensus and no good quality studies showing that this is definitely something that we should be looking at.
Okay. And now let me go to the previous question from Emily, the same patient. So would you expect the bacteria in the uterus to mirror what is found in the rest of the vagina?
A very good question. But in theory, I mean, I've seen people saying this and also the opposite. Okay, in principle, it shouldn't be the same. Okay, because the uterus is normally a closed cavity. Obviously, there is an entrance, but it shouldn't be the same. And also the bacteria in the uterus are the most important ones. The ones inside the uterus are the most important ones for the implantation process. So checking just what happens in the vagina is not enough for us to know what happens inside the uterus. Okay, probably, but the question can be asked in a different ways. Whether, okay, if I have a chronic endometritis, will this be present in the vagina? Yes, there is that risk. Okay, but the fact that there's nothing in the vagina doesn't mean that it can happen inside the uterus. Okay, so different issues. We need to always check the inside of the uterus if we really want to exclude this factor. We can't skip that. Otherwise, it would be easier.
Okay. Thank you so much once more for answering two more questions. And let me just go to the next question. We will go back to the not first question, but the previous ones. Okay. So are there lifestyle changes that may enhance the success of implantation in cases of repeated failure?
Well, if that was that easy, okay. Obviously, there are things that you can do. For example, normally we always say the healthier you are, the less likely you are to suffer from infertility. And so, for example, if you are a smoker, if you are a drinker, if you do drugs, okay, these are very easy to fix lifestyle changes. And this will certainly increase your chances of implantation. Then there is, for example, homocysteine. If you take the correct amount of folic acid, and if you do a well-balanced diet, you will have it in your vegetables and so on. Then you don't have problems at that level that are associated with thrombophilia. Obviously, if you eat fast food every day, you will have problems at various levels, and so this is obviously also causing problems at the little veins that do the microcirculation in the uterus and so on. So there are, for example, we work with a company in Switzerland. They are called ART Fertility, and what they do, they have nutritionists working for them. They correct lifestyle of the patient. They balance the nutrition. They have nutrition programs, and the reality is that we're getting very good results. We have patients that got pregnant after doing these programs that were having very negative results before that. And so I would say yes, until a certain degree. Okay, if the problem is genetic, is with the embryo, you can be the healthiest person on earth, but if you're not putting a healthy embryo inside your womb, it will not implant. So what we can do is kind of optimize all the factors that we can control, and lifestyle is definitely one of them. So I would say definitely let's control everything that we can control, and leave the rest to medicine.
Okay, thank you so much indeed once more. There are three more questions, and after that we will be finishing. So if you have more questions, go ahead, type those in right now. And I will go to the next question. So which autoimmune diseases can affect the receptivity of the endometrium?
I mean, most of them. Okay, so autoimmune diseases are there are a lot of them. Okay, they affect different systems in your body, but what and the reality, what we know is that people that have autoimmune conditions typically have a higher risk of rejecting an embryo. Um, this is so we when we do those panels to, again, we're talking about the things that are not completely proven, okay, but when we do the panels to check for immune hyperreactivity to uh, in cases of repeated implantation failure, we get a lot of anti-nuclear antibodies positive, anti-thyroid hormones positive. I mean, those are maybe the most common. Um, so, for example, thyroiditis is one of them. So we know that there is an association. It's very hard to quantify. What we do is we try to regulate it with steroids, with medication, to suppress that immune hyperreaction. But again, this is not proven. These are the things that we do, that we try to control when there is nothing else that we can do. Okay, a little bit like that other patient over there in the beginning. She apparently everything was fine. The endometrium was fine. She did the most important tests and everything looked fine. So if she was with us, what we would be doing is to check for these autoimmune diseases, to check for, I remember, for example, I can tell you a story of a patient because these patients were actually personal friends of mine. We knew each other since we were 3 years old, both of us. So we've known each other for all of our lives, and they came to the clinic as patients. And I remember that we did an egg donation treatment. We transferred 2 very good embryos and in 2 embryo transfers and no pregnancy after both of those transfers. And they had another 4 embryos, I think, and they said, well, they've registered in the public service. They were also being followed over there in the public service in Portugal, in the endocrinology service. So they were followed by them, and then a year and a half later, they came back to the clinic and said, well. We were lucky enough because one of the endocrinologists in the public hospital got interested in our case, and she ran all the tests that you can imagine and ended up diagnosing a disease that I never heard before, an extremely rare autoimmune disease. She treated that patient for that. She was saying this was in a public hospital, so it was free for the patient, but the total cost of this test was like 6,000 euros or so. But obviously the patient paid nothing because it was in a public hospital. And so they found out that she was a carrier she was affected by this autoimmune disease. They treated her, everything went back to normal, and then she came and she asked us to transfer 2 embryos, and because we were not doing her first treatment, she has tried elsewhere before, and we agreed with that, and she immediately got pregnant with twins. So this is a very clear example of an autoimmune disease that was probably the cause, and we see a lot of that. Okay, so but these are. I mean, when I say we see a lot of that, these are rare cases that we see from time to time. These are not first line situations where we can start checking for all. We do some panels to screen for the most common things, but and then we use protocols to try to control for that, but in a sort of prophylactic way. So we're treating things that we don't even know if they are there. Okay.
Of course. Brilliant. Thank you so much for your thorough answer. And let's have a look at the next question. So, in case of embryo donation, how can I know the quality of the embryo for sure, since they are not tested genetically?
There are two ways we can test the embryo. Okay, in some situations it is possible, in some other situations it is not. It depends on the regulation. It will also depend on the story of the embryo and whether we want to warm that embryo, do a biopsy, freeze the embryo again, wait for the result of the biopsy, and so on. So normally, and now I can only speak for ourselves, when we work with embryo donation, we only freeze and make available for donation embryos that have good prognosis. This is something that we assess based on the quality of the embryo development. We work with the embryoscope, with video time-lapse technology. Nowadays, also with artificial intelligence, we try to understand the real viability of the embryos, and we only freeze embryos in which we believe in. And obviously, sometimes, if that's not the case, those embryos would never be available for donation. So I would say that at least with us, there's no such thing as a bad quality embryo being donated, because we would never make them available for donation. Obviously, testing I'm very much in favor of pre-implantation genetic testing. Okay, this is not a consensual topic in the scientific community. I would say that nowadays it's becoming more and more. There's more and more consensus on this, so I'm pretty much in favor of it. So if I was the ruler, I would allow PGT for all embryos in all cases, but it's not like that, and so we cannot do it every time. But so I would say, ideally, being able to do the PGT would be great. If that's not possible for regulatory or technical questions, then we should rely on the embryo morphology and morphokinetics, because that's already very informative. Okay.
Okay, thank you so much. Of
Mhm.
course, and now we will go to our final question for today. So could the very high endometrium thickness cause implantation failure?
I would say yes. Okay. Normally, so at our clinics, we consider the optimal range to be between 8 and 16, with 16 being kind of too much. Okay. So I would normally we like it to be between 18 and 14. That's the ideal range, because obviously a very high endometrium increases the risk of polyps and other complications. But if I was to choose, if we were to choose, we prefer to have a problem of excess endometrium than the opposite, because when we have an endometrium that is growing too fast, we know that, I mean, it's just a question of fine-tuning the process, but we will end up having a good-looking, regular, not too thick endometrium. It's just a question of finding out the right protocol. If the endometrium is always at 4, 4.5, and so on, it's a lot more difficult to treat. So having to choose between the two of them, we would prefer the endometrium that is too thick. But obviously, if it is, let's say 20 or 18 or something, it can also cause problems, obviously.
Okay, thank you so much. As I mentioned, it was our final question. So thanks everyone for all of your questions and for your patience. And Vladimir, as always, it's been great to have you. And lots of interesting questions. And before we finish, as always, I'd like to ask you if there is anything else you wish to add for our ending session.
No, I mean, just to thank you one more time. It's always a pleasure to be here with you guys. I was just seeing the announcement for the next webinar on the 6th. It should be really interesting as well. So I just like to wish good luck to everyone who was watching this, who is trying to have a baby. I do hope things work for you. If I can help, please, you can send an email or contact through the my
For sure.
IVF Answers website, and you will direct the questions to us. And once again, good luck and thanks for watching.
Thank you so much indeed. Showed you this. So yes, we will be back with 3 different doctors on Tuesday. So if you haven't signed up yet, go ahead, do it. It's going to be an interesting session. No presentation, just Q&A. So if you have some questions, you can ask. There will be 3 different doctors. Also, Dr. Nisa Felix from Ferticentro will be there as well. So we are really looking forward to this event. The link is also in the chat. But of course, if you go to our website, myivfenses.com, you will find it easily as well. So thanks everyone for joining us. As always, it's been great to have you, Vladimiro, and I'm really looking forward to some more events. Take care, everyone. Have a good evening and see you soon. Bye.
Bye bye.